Now we are lucky to have Dr. Shehab El Etriby twice today, and the topic he's going to talk is very interesting. And we are looking forward to see what is new in the management of hypertension.
Thank you again. It's a pleasure to be here. So I present hypertension management and what's beyond. As we know, hypertension is
طبعا احنا بنهني الدكتور شهاب الاتريبي استاذ مساعد قسم القلب بجامعه عين شمس. Congratulations.
As we know, hypertension is a silent killer. 1 out of 2 people with hypertension doesn't know they have it. And hypertension is the leading risk of mortality worldwide. هنلاقي ان حتى في ال high income countries it is the leading risk of mortality along with tobacco use. And it's a global epidemic. The percentage of death due to hypertension is very high in all continents. And 10 million deaths occur per year, more than ischemic heart disease and more than hemorrhagic and ischemic stroke. In USA, 46% are aware, 40% are treated, and of the 40%, only 13% are controlled. We conducted in Egypt the 100 million wellness program to know the mortality data in Egypt, and the non-communicable diseases accounted for 84% of the total death, and 40% were due to cardiovascular disease, 30% were due to raised blood pressure. Combining the data, we found that the adults in Egypt less than 60 years, 26% were hypertensive, and more than 60 years, half the population was hypertensive. And Egyptians belong to the salt-sensitive group, 30% of non-hypertensive individuals and 50% in those with hypertension. The people who are aware of the hypertension were only 38%, and only 8% of these patients were controlled. As we know, the cardiovascular disease death doubles with each 20 millimeter mercury increase in the systolic and 10 millimeter mercury in the diastolic, reaching an 8-fold risk if you have a systolic blood pressure of 175 over 105. And the impact of high normal blood pressure on the risk of cardiovascular disease is more than the normal and the optimal, which is less than 120. And hypertension can lead to severe health complications and increase the risk of several serious and potentially life-threatening conditions like coronary artery disease, heart failure, stroke, chronic kidney disease, dementia, and peripheral arterial disease. The blood pressure has multiple regulatory pathways, including the sympathetic nervous system, renin-angiotensin system, and the total body sodium. So it needs multiple medications with different mechanism of action to be controlled. What's the rationale for combining a drug therapy in hypertension? It's necessary for good control of hypertension, maximizes the efficacy, and minimizes the side effects as you'll use lower doses of each drug. And of course, some drugs may antagonize the adverse effects of pharmacological actions of the other drug. The 2013 recommendations of the ESC and ESH is there are favorable combinations like ACE inhibitors with thiazide, ACE inhibitors with calcium antagonists with ARBs, and ARBs with thiazides, and beta blockers with thiazides in a certain group of patients. As we know from the guidelines 2018, that the initial therapy for hypertension is a dual combination of ACE or ARBs plus a calcium channel blocker or diuretic. Only in special situations you can start with a single drug. If the patient is frail, more than 80 years, he doesn't have an accompanying person with him at home, and a systolic blood pressure less than 150 millimeter mercury, you may start with a single drug in a single pill. Then, if not controlled, you can have a triple combination, preferably for adherence with a single pill, ACE or ARBs plus calcium channel blockers plus a diuretic. If not controlled, you can add another pill with the triple combination, spironolactone or another diuretic, alpha or beta blockers. Of course, beta blockers can be used in any step of these if there is a compelling indications like AF, post-MI, or heart failure. And it was found that at least 75% of patients will require combination therapy to achieve the blood pressure target. As you see here, in all continents, 2/3 of the population with hypertension need more than one drug. The importance of the combination is that using a big dose of a single drug may not be as effective as combining drugs. The combination at half dose lowers the blood pressure more effectively than when using a single large dose of a single drug. The most important problems faced by hypertension today is the increased incidence with the gap in awareness. As you see, there were only 38% who had hypertension were aware. Low rates of blood pressure control and drug-related factors, whether you need to give it only once per day, a single pill combination, whether it's cost-effective, whether it's well-tolerated or not. And as we know from the guidelines, the grade 1 hypertension starts from 140, but we must diagnose the MAS hypertension and the white coat hypertension. There are several potential risk factors for hypertension, like sex, age, smoking, total cholesterol, and HDL, diabetes, overweight, and sedentary lifestyle. If you have no risk factors, with up to grade 1 hypertension, you are still at a low risk. But if you have more than or equal 3 risk factors at grade 2 hypertension, you are at high risk. If you have diabetes without organ damage, you start to be high risk from grade 1. And in stage 3, if you have end organ damage, established cardiovascular disease, or CKD grade more than or equal 4, you're at very high risk, even if you have a high normal blood pressure, 130/85. The thresholds for treatment by the guidelines up to 79 years old is 140/90, and in more than or equal 80, as we said, 160/90. And you can use any class, including the ACE, ARBs, beta blockers, calcium channel blockers, and diuretics. What matters is that you decrease the blood pressure. As we said before, in the SPRINT trial, there were patients aged more than 75 years old, and they were frail. The significant decrease in the systolic blood pressure, less than 120, was compared to less than 140. There was no significant difference in the intervention and control groups regarding the orthostatic hypertension and the injurious falls. They were, of course, more in the intensive treatment group, but were not that significant. And as we said, the benefit of decreasing the blood pressure outweighs the risk. I won't say it again, we said it before. The number needed to prevent death was 90. Now we shift to the STEP study group. This was a Chinese study done on patients 60 to 80 years of age. Compared the intensive treatment with the systolic blood pressure goal of less than 130 versus the standard treatment, which was 130 to 150. And over 48 months, the mean blood pressure in the intensive treatment group was less than 130. It was 126. And in the standard treatment group, it was 135 So the difference was only 9 millimeter mercury, and despite this difference, there was a significant decrease in the primary composite endpoints by 26%. It decreased stroke 33%, acute coronary syndrome, heart failure, mortality due to cardiovascular causes, but it didn't differ in the AF or the all-cause mortality. There was also the Astral study in the uncontrolled hypertensive patients treated with a fixed dose of ramipril and hydrochlorothiazide. It included patients that were not controlled by an ACE inhibitor or diuretic or any other monotherapy not containing a diuretic fixed dose. It was done over 8 weeks, and it decreased significantly the systolic and the diastolic blood pressure, the systolic by 32 and diastolic by 18 millimeter mercury, with few adverse events. Of course, as there is an increase in age, even with normal or high normal blood pressure, you're at increased risk of stroke or coronary artery disease. The hypertension causes end organ damage, of course, hemorrhage, stroke, LVH, heart failure, and renal failure, peripheral vascular disease, and retinopathy. And there is a preferred treatment with ACE in certain conditions like LVH, microalbuminuria, renal dysfunction, previous MI, AF, and end-stage and peripheral renal disease. Also, in metabolic syndrome and diabetes, the ACE inhibitor is the preferred treatment agent. Ramipril as an ACE inhibitor has a great cardiovascular protection proved by many trials. The first was the HOPE trial in 2000, which showed that the ramipril was well tolerated up to 10 milligrams, causing only cough, hypotension, but was not that significant. It decreased the composite outcomes of MI, stroke, and death from cardiovascular cause by 22% compared to placebo, and also secondary outcomes like revascularization, heart failure, worsening angina, and new onset diabetes. There was significant reduction in the total fatal and non-fatal MI, and in heart failure by about 23%. The MITRA Plus study was done on patients with ST elevation myocardial infarction who received ACE inhibitors. 4.7% received ramipril, while 39% received other ACE inhibitors, and it showed that the ramipril saves significantly more lives than other ACE inhibitors that were used in this trial. Within only these 3 weeks of admission, there was an APRIS study in the post-revascularization study in patients with asymptomatic moderate LVH after invasive revascularization. It included ramipril 2.5 up to 10 milligrams over 2.5 years, and it showed a significant reduction in the cardiac death, acute MI, or clinical heart failure by 58%. The last study was done on elderly patients who took different ACE inhibitors after acute MI. Is it a class effect or is it the ramipril only? In patients 65 years of age or older in Canada, over 7,500 patients, and showed that ramipril decreased the primary endpoints and improved the survival more than other classes of the ACE inhibitor. So my take-home message is that cardiovascular disease is the leading cause of death worldwide. Hypertension is the #1 risk factor for global mortality. Blood pressure control should be coupled with risk factor and cardiovascular disease prevention. ACE inhibitors show a mortality benefit. Ramipril shows a potent antihypertensive effect and also cardiovascular protective effect. Thank you.
Thank you, Dr. Shehab El Etriby. كلير مسج حقيقه دكتور شهاب. احنا عندنا طبعا المونوثيرابي خلاص الجايد لاينز قالت ان 3 كونديشنز: العيان الفريل بيشنت، العيان الالدير اللي اكتر من 80 سنه، الجريد 1 لو ريسك بيشنت. فكده خلاص دول هديهم مونوثيرابي، لكن اذروايز انا هدي كومباينيشن ثيرابي. اختياري للدراجز لازم يكون الدراج ده tolerated, saved, coverage 24 hours, central blood pressure reduction، يعني ما يكونش peripheral blood pressure بس. علشان كده يمكن الجايد لاينز في حته كده احنا كلنا بيقول لك ايس اور اربس، ونشعر وكأن الاثنين واقفين على نفس الستاندر، لكن الحقيقي لا، هو ايس ثم الاربس، لان الايس طبعا عامل طبعا كل الترايلز الايس بتؤيد الايس. حتى في ترايل قالت ان الاربس هتزود الميوكاردال انفاركشن والستروك، بس هو مش هتزوده، هي not protect the patient enough like ACE. فاذا الايس هو اللي هيبقى هيبروتكت البيشنت.
وبعدين ما بين قوسين اور اربس
يعني يمكن بس الحاجه الوحيده اللي عايزين نتفق عليها ان الايس if not tolerated، اذا كان الريتيتيف كاف والعيان مش قادر يتعايش معاها، دي الحاجه اللي هتخليني تشيفت تو angiotensin receptor blocker. لكن otherwise it's still الايس inhibitor the first choice in treatment of hypertension، especially طبعا الرامبريل والإنالابريل، دول اللي على رأس الايس inhibitor. Thank you دكتور شهاب.
Thank you, Dr. Shahab, for this very comprehensive lecture highlighting the importance of the hypertension as the first and most modifiable risk factor for cardiovascular disease. What concerned me about this presentation is the situation in Egypt now. Still, hypertension is a prevalent disease in Egypt. It's almost 30% of the Egyptians have hypertension, but the things have improved. Recently now, the awareness of hypertension among the Egyptians is almost 40%, 39%, which is different from the national hypertension projections in the 90s. And also the rate of control has improved. That for several reasons. Level of education has improved in Egypt, and also awareness of the hypertension has improved, and also the presence of single pill combination have improved the compliance and things. In your perspective, what do you think, what more we can do to control hypertension among the Egyptian population?
هي بس المشكله في البيشنتس ان هم بيروحوا للدكتور الغلط. يعني يعني هو hypertension should be treated by cardiologists عشان الكارديوفاسكولار ريسك، واحنا عارفين مين البيشنت اللي نديله ايه، يعني ايه الكلاس اوف دراج اللي نديه للبيشنت. لما نلاقي بيشنت مثلا ماشي على بيتا بلوكر وهو مش محتاج بيتا بلوكر، ويقعد يزود في الدوز بتاعه البيتا بلوكر والضغط ما بيتحسنش، يقول لي طب ما انا زودت الدواء ما بتحسنش ليه؟ طب ما يعني بيبقى راح لحد مش اكسبرت في الموضوع. بلس ان هو يعني احنا عندنا الاسكيميك هارت ديزيز فيري بريفالنت، وبيتابعوا ال LDL، فبالمره بنتابع معاهم طبعا الهايبرتنشن از ريسك فاكتور. فمتهيألي ان هو لازم يبقى في awareness programs ونقول لهم ان الهايبرتنشن ده is a cardiovascular disease. It's not an internal medicine. It's a cardiovascular disease, should be treated by a cardiologist.
شهاب متألق كالعادة، مش بس في الانترفنشن ده، حتى في البريفنشن كمان. تاني القصة اللي أثرها أخونا الدكتور ياسر بيه، ACE versus ARBS. خلينا نطلع واحنا كل واحد عندنا قواعد محددة. لما اجي اقارن بالاثنين in the setting of acute myocardial infarction قد ايه؟
ACE.
Definitely. In the setting of heart failure قد ايه؟ In the setting of hypertension قد ايه؟
hypertension بس ممكن الاثنين.
صح، هو دي الاجابه المظبوطه. الاثنين عندهم القدره ان هم يوطوا البلاد بريشر بنفس الدرجه. لكن cardiovascular protection wise مين اقوى؟ الايس. تمام. In the presence of chronic kidney disease
يعني في كلام، بس يعني الايس اكتر.
تمام. هو الاربس عشان توضح ده مش موضوعنا النهارده، بس احنا مش بنبص لها ان هي one entity. ما هواش واحد بيساوي، كل واحد عليه ترايلز وعليه ديتا في مجال معين. الاربس في حاجات عليها ديتا في الهارت فيلير، حاجات عليها ديتا في الهايبرتنشن، في البروتكشن، في الرينال بروتكشن. ده مش مجالنا في السيمبوزيوم ده اتكلم عليها، بس الاربس ما هياش وان انتيتي. بالنسبه لايس ستيل هي البريفيرد، الا لو كان في مشاكل بالنسبه لها علاقه بالسايد افكت، ساعتها بدي الالترناتيف اللي بيساويها في المجال اللي بدي فيه. فدي بس اللي انا عايز اطلع منها. دكتور حسن بيتفضل.
دكتور شهاب، سؤال على دراسة اتنشرت 2018 لقت ان بعد 5 سنين في 22% increase in cancer lung في الناس واخدين ايس، وبعد 10 سنين 31% increase in cancer lung. ولقوا ان معظم الحالات اللي كانوا بياخدوا الايس كانوا للاسف راميبريل، 7% بس كانوا الكوفرسيل. فايه رايك، هل نمتنع عن مثلا ندي الايس للسموكر، عشان السموكر عندهم طبعا 26% انكريز لوحدهم؟ بس الدراسه دي يعني اثارت بلبله ساعتها، ولا زالت برضو بيتكلموا بس بينتقدوا، بيقولوا يعني ايه ما تاخدوش في بالكم هو سمول انكريز، ولما حسبوها بير 1000 لقوا انها 1.3 انكريز بير 1000 which is small ratio.
يعني وبصراحه ما اقدرش بيسد على الستادي دي ان انا اوقف حاجه، يعني مش حاجه، ما فيش كلير كورليشن يعني.
دراسه منشوره الحقيقه، ولقوا ان كل ما تطول 10 سنين الانكريز كانسر لانج، وللاسف معظم الحالات دي كانت بتاخد راميبريل و7% كان.
طب وهل كانوا يعني دول كلهم كانوا نون سموكرز؟
لا انا ما طلعتش عليها، بس انا بقول
يعني
انا
لازم
من ساعه ما قريت الدراسه دي
آه.
بطلت اديه للناس السموكر، عشان دول عندهم خلقه ربنا انكريز، فقلت يعني ابعد عن الشر واغني له. عندنا اس انهبيتور كتير. طبعا الترايتس هيزعلوا، معلش.
In this session.
Any further questions? Thank you very much, Dr. Shehab, and thank you.